Hello, everyone. My name is Zachary Rasmussen, and I am a Chief Resident in Emergency Medicine at University Hospital's Cleveland Medical Center. Today, I will be talking about Medicare. This talk is not a comprehensive description of Medicare. It will only be about 10 minutes to provide a basic understanding of a program that has been in place for over 55 years. This will allow for further discussion and demonstrate why all healthcare providers need to be well educated about this program to ensure high-quality patient care in the future. Since the whole of Medicare cannot fully be discussed in 10 minutes, I'm going to focus on trying to demonstrate the importance of Medicare, explain how Medicare developed into the program we know today, and hopefully generate more interest in physician involvement in health policy. So why should you care about Medicare? At the individual level, for anyone who receives a paycheck, you'll see taxes taken out of their pay. For me, I pay about 18% of my income to federal taxes, 6.2% to Social Security, and just under 1.5% to Medicare. To put this into context, during a single 12-hour shift, 2 hours of work are for federal taxes, 45 minutes for Social Security, and 10 minutes for Medicare. So this amount of time in each 12-hour shift is going towards paying for these programs. Now, I'm in emergency medicine, and I'm looking to have a long and enjoyable career, which will likely mean a lot of 12-hour shifts. This adds up to a lot of time that each taxpayer puts forth individually in supporting the Medicare program. Next is the payer mix of your practice. At my hospital, 43% of patients use Medicare. Across the United States, Medicare is one of the biggest payers in almost every healthcare system. This is how your hospital or group is being paid, and any changes in your payer mix or compensation from one of these programs, of which Medicare is one of the biggest payers, can have huge repercussions. So now, between taxes and your system's payer mix, you can see the importance of Medicare even if you are not personally receiving Medicare benefits right now. But how did we get to the system that we have now? After World War I, the United States saw the negative effects of post-war inflation in Germany. And so as World War II was coming to an end, the United States government put wage controls in place to avoid post-war inflation in America. The labor groups then threatened to go on strike due to these wage controls, so the government allowed employers to offer health benefits which were exempt from taxes. In an environment when there were not a lot of workers and there were a lot of open jobs, the employers needed to have something to attract employees to their programs, and so they began offering health benefits as part of their employment packages to attract laborers to their offers. This worked well for people who were employed or were at an age where they could be employed. However, eventually people want to retire. The government realized the retired population would no longer be receiving these health benefits, and so they created Medicare in 1965 to provide medical insurance to those over 65 years old. This included Medicare Part A and B, which is now called Original Medicare. From a first look, this was a fairly simple and elegant solution to allow people less than 65 years old to receive health benefits from their employer, and those over 65 could receive Medicare. As we all know, this is anything but a simple program now, as Medicare has since grown to become a pretty large system. As of 2018, Medicare accounts for about 15% of the federal budget, and this is over $600 billion. So how did we go from a simple sounding solution in 1965 to what we have with Medicare today? In 1972, we realized that people with disabilities or end-stage renal disease have difficulty maintaining full-time employment and so are not receiving these health benefits, and so they were added into the Medicare program. Similarly, in 1982, hospice patients were added to the Medicare program because they are often unable to work and are not always over 65 years old when they get put into the hospice program. As more people were added to the program, it became more and more expensive for the federal government to pay for on its own. The federal government realized that the cost of Medicare was only going to continue to rise, and some patients were already having difficulty paying their share of costs in the program. And so they mandated that states cover the cost of Medicare for people with annual salaries less than the federal poverty level. Today, the current federal poverty level is set at just over $12,000, and so the people who are having Medicare paid for by their states are truly those in need. In the 1990s, the state buy-in was expanded to include individuals up to 135% of the federal poverty level. Also in the 90s, Medicare Part C was introduced, which allowed for Medicare patients to purchase additional coverage through private insurance companies within the Medicare program. In 2001, patients with ALS became eligible for Medicare, similar to other patients with disabilities. And Medicare Part D was added in 2006 to provide coverage for retail prescription drugs. Then in 2010, the Affordable Care Act was passed, and this added free coverage for specific cancer screenings and primary care visits while introducing alternative payment strategies that aim to incentivize improved longitudinal care of patients. Then in 2015, the Medicare and CHIP Reauthorization Act was passed and again implemented new methods of reimbursement with the goal of transitioning from a fee-for-service model to an increased focus on value and quality of care for the patients. This has led to the Medicare program we know today with four parts. Broadly speaking, Part A is used to pay for inpatient services, Part B is for outpatient services, Part C is the Medicare Advantage plans where patients can choose to purchase additional coverage within Medicare, and Part D is for prescription drug plans. Now let's take a look at how procedures we do in the emergency department lead to the hospital making money for Medicare. First, a service is provided in the ED. Each service that we provide is associated with a current procedural terminology code. Then each CPT code has been assigned a relative value unit, and this is multiplied by the conversion factor to calculate the total amount of reimbursement. Here is a specific example of how this process works for a laceration repair. Say someone fell and has a small cut on their arm that I'm going to repair. This falls under CPT code 12001, which is associated with 1.27 RVUs. Multiplying by the conversion factor results in a payment of $47 to the hospital or the group that did that service. This report from ACEP examines how Medicare reimbursement has changed over the last 2 decades. Between 2000 and 2020, emergency medicine reimbursement for Medicare has decreased by 29%. This is not unique to emergency medicine, as lots of other specialties have seen this downtrend during the same time period. Looking to the future of emergency medicine, Medicare and other governmental programs are important for reimbursement because they set the market prices for services. Like we saw at the beginning, 43% of my hospital's patients are on Medicare. So if Medicare makes any changes to their reimbursement, immediately those 43% of patients will have changes. And then beyond those 43%, other payers that the hospital negotiates with see the new levels that Medicare is using, and this creates a new standard. So if Medicare decreases their payments, the other insurers can decrease as well to minimize their own spending while still remaining competitive within the market. This highlights the need for continued activity in searching for sustainable payment system reform. In summary, Medicare is important for everyone working in healthcare because they are one of the biggest payers across the country. And Medicare is important for anyone who receives a paycheck, since there is a significant portion of your pay going towards supporting this program regardless of what your job is. Medicare originated from health benefits created during World War II wage controls and has since grown to account for over $600 billion in the federal budget. We have seen continued downtrends in Medicare reimbursement over the last 2 decades as the government searches for ways to decrease spending on Medicare. Now, I want to encourage all providers and anyone involved in healthcare to educate themselves on health policy and economics so that we can continue to advocate and provide awareness to this issue to create effective changes and involve physicians in the solution for the future American healthcare system. Here are a few of the references I used during this talk. If you have any questions or comments, please put those below. Hopefully you learned a little bit about Medicare, and thanks for listening.